Good morning. Welcome to another NIPMED tutorials. Today we'll be going through obstructive uropathy. So, obstructive uropathy, like we said, an obstructive disease involving the urinary tract. Based on the time frame, it could be an acute or chronic obstruction. It could be a partial or complete. Complete does not allow urine to flow after or beyond the point of obstruction, while partial still permits some degree of urine flow. It could be unilateral or bilateral. Remember that bilateral will produce signs of renal impairment, unilateral wouldn't produce. And it could be hydronephrosis when the renal calyceal system has undergone dilatation because of the pressure that has been transmitted upwards, making the kidneys pelvis to dilate, or hydrourethra, referring to the ureter, or bladder distension if the obstruction is at the level of the urethra, so the bladder becomes distended. So, some simple things you should know. Bladder outlet obstruction is more common in males because of the presence of the prostate. Now, with age, in some males, this prostate undergoes hyperplasia. So, benign prostatic hyperplasia could lead to obstruction of the urethra. You will know the urethra, we have the prostatic urethra. It's a part of the urethra located within the prostate. So it could undergo obstruction as the prostate gland enlarges, or it could be secondary to prostate carcinoma. Okay, now both women and men are at risk of having urinary retention that can occur due to complication of chronic UTI, this formation of some fibrosis or strictures. Okay, and also in presence of chronic tubular interstitial diseases, there could be some form of renal obstruction also. So when there is an obstruction, right, there is a narrowing or there is a high resistance that is impeding the flow of urine. What happens? The kidney tries to, not kidney, urine tries to flow through the path of least resistance. It's part of fluid hemodynamics. Okay, so what happens is that the pressure is then transmitted upwards. That's to the ureter, to the pelvis, the calyceal system. Now, the level of the Bowman's capsule, what this does is that it increases the pressure in the Bowman's capsule. And we know that filtration requires the pressure gradients that's present within the glomerular capillaries and the Bowman's capsule. So if the pressure gradient is high in the glomerular capillaries, it will lead to favor filtration. While the pressure gradient is high in the Bowman capsule, it doesn't favor filtration. So when that occurs, there's going to be a decrease in the glomerular filtration rate. Okay, now what happens? So we have an increased pressure in the Bowman's capsule that is decreasing GFR. Now, general filtration rate, the fluid to be filtered comes from different arterioles. But since filtration has been impaired, what happens? The pressure then gets pushed to the afferent arterioles, which then decreases renal blood flow. Okay? And there's also going to be impaired tubular function because of the pressure that has been pushed up. Alright? So this is a simple basic pathogenesis. Increased pressure in the Bowman's capsule, impeding glomerular filtration, impeding or reducing glomerular filtration rates, decreasing renal blood flow. Okay. Now, as to the time frame in which the injury caused by an obstruction or uropathy, obstructive uropathy is reversible is still debatable. Okay, but less than 1 week, there's likely going to be complete recovery. Then greater than 8 to 12 weeks, the likelihood of recovery is usually suboptimal, or we don't expect complete renal recovery. Okay, all right. So the etiologies, there are plenty, but just know it could be intrinsic to the kidneys, it could be extrinsic, and it could be from the lower urine tract. So intrinsic obstructions such as stones, papillary necrosis, clots, transnodular carcinoma. Transitional cell carcinoma is the carcinoma of the urinary bladder, and one of the most common risk factor for transitional cell carcinoma is exposures to schistosoma hematobium. So chronic schistosomiasis puts the patient at risk for transitional cell carcinoma. Another common cancer of the bladder is squamous cell carcinoma, in which smoking puts the patient at risk. Okay, the extrinsic retroperitoneal fibrosis. Remember, the kidney is a retroperitoneal organ together with the ureter. So let's say following chemotherapy, now someone develops retroperitoneal fibrosis from chemotherapy, it can lead to obstruction of the urinary tract. Another thing that can occur is if they have some masses in the uterus or in the ovary, or if somebody has a blood clot that is involving the Riverian vessels. You know this anatomical structure of water under the bridge, meaning that the ureter actually goes underneath the vessels. So if there's a malignancy, for example, now, and there's obstruction and there's a thrombus formation in the vessels, it could compress the ureter. The compression of the ureter will then lead to reduction in urine outflow, and they can lead to hydroureter and then hydronephrosis. Other things like endometriosis, ureter ligation, and even some surgical procedures. Okay, the wide tract obstruction, the most common one we have to know is benign prostatic hyperplasia, prostatic cancer, presence of bladder cancer also, and a neurogenic bladder, which can be due to trauma of the spine or trauma to the spine, trauma to the cauda equina. Okay, all those things could affect the bladder function and cause neurogenic bladder. Also due to diabetes mellitus also. So the symptoms of obstructive uropathy literally depends on the cause of the obstruction and the location of the obstruction. Okay, so we have obstruction now called below the bladder. We have symptoms such as feeling of incomplete void. We might have dysuria, that's difficulty urination. We might have terminal dribbling, that's after they urinate, they still have some form of drops. We might have a decrease in urinary stream. Okay, those are some. We might even have urinary frequency. Those are some symptoms might see in obstructive uropathy. Okay, if the obstruction is below the bladder. All right, there's going to be pain. Pain is related to the location, duration, and the severity of the obstruction. The obstruction is acute. There will be severe pain because of the distension of the collecting system or renal capsule, and also we can also see some form of abdominal distension, especially when the bladder has been so enlarged and engorged with fluid. You see serious fluid urinary retention, very painful. There might see renal colic, which is severe back pain that radiates to the groin, and the patients have difficulty staying in one place. They're always rolling and agony, crying, shouting. There might be nausea and vomiting also. Okay, so then if the obstruction is bilateral and it has progressed, we then have involvement of the kidneys leading to renal failure. We can start seeing signs like hypertension. That means that the patient is tilting towards some form of chronic renal failure. So laboratory findings. Remember, for almost all kidney pathologies, the laboratory test you want to do is the electrolytes, urea, and creatinine, and then maybe a urinalysis. Those are the basic laboratory tests one want to do. Okay. So in case of obstruction, first thing is that the kidneys lose the ability to concentrate urine because there is tubular damage, and the tubules that we have, urine is concentrated. Okay. So the urine is usually isostemuric. That is, the specific gravity of the urine doesn't change. Okay, does not get more in case of dehydration, neither does it get less in case of hyperhydration. So they cannot concentrate or dilute urine. Then later, if the tubular damage continues at the level of the distal tubules, we have some channels that are necessary for the reabsorption of bicarbonate and then the secretion of protons. So when those tubules are damaged, we can have distal renal tubular acidosis. Okay, this is called type 4 renal tubular acidosis. They could also develop. They might have symptoms of renal insufficiency, like I said, if it is bilateral. Okay, or if the person has only one kidney that is working, and that kidney undergoes obstruction. So initially, but when we do urea creatinine, the serum urea creatinine ratio initially will be greater than 10. Some books put it at greater than 20. When we did in the lecture on acute renal failure, we remember that pre-renal injury usually leads to a serum urea creatinine ratio greater than 20. That's at the initial phase. Okay. The same thing with obstructive. At the initial phase, it gives a high serum blood the ratio of the blood urea nitrogen to creatinine is quite high. But later, because urea is still reabsorbed, but later when the glomerular filtration rate worsens and when the tubules become damaged, the ratio of the serum urea to creatinine starts getting less. So it starts getting less. So this ratio greater than 10.10 ratio 1 usually at the early stage. Okay. Secondly, you can have some form of nephrogenic diabetes insipidus because it is the level of the collecting tubules that the antidiuretic hormone works. So in this case now, because the tubules are being damaged, they are not responsive to antidiuretic hormone, so we might see some features of what? Hypernatremia. Now when there is chronic renal failure, we start seeing signs of what? Chronic kidney injury over a long period of time. Now this urinary stasis puts them at risk of infection by organisms like the gram-negative organisms, Proteus mirabilis, E. coli. Proteus itself produces urease that breaks down urea to ammonia. Ammonia raises the pH, making the person more prone to struvite stones. Okay, so you can see magnesium and phosphate stones. So these are some common laboratory findings we'll see, like we just spoke about. So imaging, renal X-ray. X-ray will show us the type of stones, especially if we have radio, if they are radio opaque stones. That's what X-ray will show, some form of radio opaque stones. So some radio opaque stones will be calcium oxalate stones or struvite stones. These ones will be seen on X-ray. Okay. Ultrasound also will show us. Ultrasound will also help us in seeing if there's bladder distension. So we see that the volume of fluid in the bladder is much, and then the my shows a thickened bladder. And ultrasound is very relatively sensitive and specific, about 90%. Okay, you can give a false negative if the obstruction is still early and the patient is dehydrated. So there's not much urine in the bladder. Okay, what ultrasound does is that it's trying to get the volume of fluid within the urinary bladder and checking for hydronephrosis or hydroureter, okay, dilatation. All right. So when the fluid there is much, the ultrasound will still also a distended bladder. Okay, and if the obstruction has been chronic, it can show some form of what? Bladder thickening of the bladder wall. This will be seen on what? Ultrasound. Then we could see we'll do a spiral CT. This one will help us in getting stones. This one is highly sensitive for checking if there are stones. So a negative spiral CT will highly rule out the stone. Then for the intravenous spinography, which one follows infrared contrast and monitor the contrast that is created to show us areas of narrowing, to show us areas of what? Formation of stones if they are there. Documenting post-void residual urine by bladder catheterization on ultrasound is an integral part of the initial evaluation. Okay, so you check it, you expect a certain amount of urine to be out of the bladder after the patient has what? Voided. When patients that have obstruction, they have difficulty removing it. You can also do a DRE, which is very important. A DRE will reveal some things. If it's cancer, it's usually a prostate is enlarged, you can feel it from the digital rectal examination. So if the prostate is just benign, you see an enlarged median sulcus, and the mucosa of the prostate is free, of the rectum is free. But malignant prostate, the mucosa of the rectum is healed and the median sulcus is quite obliterated. It's not easy to palpate. Okay, these are some things you can find on digital rectal examination. All right. So treatment is to relieve the obstruction. Obstructive uropathy usually is an acute renal, it's an emergency, so you have to relieve the obstruction as soon as what possible. Okay, so the patient comes to you having pain, suprapubic pain, and then you examine the patient, discover that he has some urinary retention. You try and pass a catheter immediately to relieve that obstruction. Catheter now could be transurethral or suprapubic, try if it's bladder outlet. Then other causes of obstruction will be treated based on the what etiologies. Okay. Now stones are usually less than 5 to 6 minutes, usually pass spontaneously. So you encourage hydration. You encourage what hydration because hydration increases urinary production. Increase urinary flow, less stasis, and then helps in pushing out the urine and then the stone. For stones that are larger, then you might now need to do some lithotripsy. It could be extracorporeal shockwave lithotripsy. The patient has very enlarged stone and is in serious urinary retention. You might find a way of what? Doing some urinary diversion. Okay. Right. So you want prevention can be done both medically and non-medically. One of the thing is that when you start observing possible risk factors that put the person at risk of developing an obstruction, right? Then you start taking into account the important preventive measures you want to use to prevent it. For example, now some patients that have symptoms of benign prostatic hyperplasia and on examination reveals them, you might want to start them on some alpha blockers to reduce the growth of, to reduce the pressure of the sphincters. One of them is tamsulosin with an alpha 1D blocker. It could help. Another one is prazosin, but tamsulosin is more specific for the prostate. Then you can also use some agents that are 5 alpha reductase inhibitors to reduce the grades of the prostate, such as finasteride. So that's some medications that could be used. Then for patients that have bladder spasticity, you could use some form of anticholinergic agents like oxybutynin, but take into account that contraction of the detritus muscle also helps in helps in pushing out urine. So using as anticholinergic agents to reduce bladder spasticity, you may also put them at risk of what urinary retention. Okay, right. Thank you, and I'll see you next week.